Yep.
All right. Hello, everyone, and welcome to our second webinar for the ANZICS CORE Let's Talk Data series. My name is Jen Hogan, and on behalf of the team, I'm very pleased to introduce Dr. Paul Secombe as our special guest speaker today. So thank you, Paul, for your attendance.
Right.
We also have about 80 attendees, hopefully joining us from across Australia and New Zealand. We'd love you to be involved in today's proceedings by using the Q&A tool on the bottom of your screen if you'd like to post a question today, and we'll get some time at the end of Paul's presentation for him to address these. And now to Dr. Paul Secombe, who is an intensive care specialist and researcher based in Alice Springs. Paul has a particular interest in Indigenous health outcomes, particularly in the areas of critical illness, obesity and nutrition, and he has a number of peer-reviewed publications within these areas of interest. Paul is a supervisor of training for the College of Intensive Care Medicine and is an honorary reviewer for a number of peer-reviewed journals. In 2017, he was awarded the Northern Territory Clinical Educator of the Year and is the 2014 recipient of the Norvidalia Grant. Paul has a Master of Clinical Science through the University of Adelaide and is a PhD candidate with the School of Public Health and Epidemiology at Monash University. He also holds a number of academic affiliations. Here at ANZICS CORE, we're very fortunate to have Paul as the Registry Associate Clinical Lead, a position which engages him in quality assurance activities to improve ICU outcomes. And this is a perfect segue to his presentation today. Can registry data be used to improve outcomes for vulnerable populations? So thank you, Paul, and it's over to you.
Good. Thanks very much, Jen. Thank you. I wish you hadn't said how many people were dialing in. It's, I was already feeling some trepidation about presenting today, having seen Dave's excellent presentation a month ago and thinking I had a very high bar to try and get to. Thanks everyone though for dialing in. It's unusual experience presenting to a screen rather than to an auditorium. I guess the advantage being that I can't see the empty seats in the auditorium that I'm usually speaking to. Before I go on, I guess a couple of things. I think probably the whole point of these series of presentations that ANZICS is and ANZICS CORE is putting on is to highlight the important role that the ANZICS representative registries, or the ANZICS registries representatives, the data collectors, play in collecting the data that we use for benchmarking quality assurance and that go on to provide important data that we use in research, and also to highlight the breadth of data that is held within the registries that ANZICS CORE oversees. I've said it before and I'll say it again, I'm always surprised that more ICU trainees aren't accessing this data to do their projects. It's sitting there, it's all ready to go. There are any number of ready-made projects that could be done using this data. Before I go any further, I would like to acknowledge country. I'm speaking to you from Mabuntua country in Central Australia. The Aranda people are the traditional custodians of this land. They always have been and they always will be. It's a privilege for me to live and work in this land and I acknowledge their elders, past, present and emerging. I have some affiliations to declare. The affiliations are there. I have no conflicts. I do have a couple of disclosures and I'll make an apology at the end of it. What I'm going to do today is describe the data that is contained within the ANZICS registries. What the data hides, though, are millions of untold stories. And we lose these untold stories when we're looking at this big data. It's also, I think, somewhat self-evident, but probably important to articulate that I can't imagine what it's like to be part of a vulnerable population. I am not Aboriginal nor Torres Strait Islander. I have a home that I go home to. I do enjoy alcohol, but I do not have an alcohol misuse problem and I don't use injecting drugs. So although I don't belong to any of those vulnerable groups, and although I can't imagine what it's like to be part of a vulnerable population, I don't think that stops me from describing the data as it applies to them in critical illness. One of my large interests is in Indigenous critical illness. I need to acknowledge up front that I'll be using the term Indigenous throughout. Within Australia, that applies, that means it's Aboriginal and Torres Strait Islanders. The registry uses the term Indigenous because it's a binational registry. There is an important Maori component to it, which I won't be describing today, and this forms part of the apology. To any New Zealand colleagues that have dialed in, my apologies. Most of what I'll be talking about today is Australian data, and therefore it's Aboriginal and or Torres Strait Islander. I've alluded to the fact there's millions of untold stories. The other thing that the data hides is the diversity which exists within each of the vulnerable groups and the Indigenous population in particular. The diversity in terms of language can be seen by the map you can now see on your screen, which is language groups within Australia. There is obviously also vast cultural differences depending on the land to which they call home, but depending also on degree of urbanisation, level of education, etc., etc. Today, I'm just going to cover a couple of things. First of all, I'm going to touch on a group of patients for whom arguably we haven't paid enough attention over the years, and that's something that's loosely called vulnerable populations. I'm going to highlight what the core registries can tell us about these groups, and hopefully demonstrate to you that what would seem sometimes to be our best efforts to hide within our ivory towers and within the confines of our intensive care units, critical care does have an interface with public health, and potentially critical care physicians and intensivists have an important role in this, and certainly what the core registries can tell us may have some important messages for our public health colleagues. And finally, highlight the power that is held within the COMET database in particular, and again, apologies to those of you who are still using aortic, because there's lots of things we can do within COMET, including some reasonably unit-specific things that I'll highlight to you as we go along, and hopefully, fingers crossed, it might be an incentive to those still using aortic to transition across to COMET. So first of all, I guess the question has to be asked, what is a vulnerable population? I think we've all sort of got a sense of what they are, and nailing down an exact definition even within the literature is somewhat difficult. There are 3 definitions there on the screen pulled from different papers within the literature, and that's not only critical care literature, that's also world literature. And the last one you can see there is probably particularly salient to our Victorian colleagues at the moment, given the crisis with COVID, particularly in nursing homes there. So although you could probably reasonably argue that the organisations, whether that be the individual nursing homes or varying levels of government, could have anticipated the crisis that would arise in there. Certainly what we've seen is that the residents of nursing homes are unable to cope with, resist the impact of COVID, and it's wreaking absolute havoc through the nursing home. So I think we can see there a perfect example of what a vulnerable population is, and the impact that various things, whether they be disaster or whether they be pandemic, might have on those populations. Who are they? Again, the list is long. This is not an exhaustive list. I think there would be little argument about a few of the things that appear on that list. There might be some controversy around some of the other ones, particularly perhaps the obese. Are they a vulnerable population or not? Are regional Australians a vulnerable population? Again, it depends on the definition you use. If you think of it as life expectancy, certainly the life expectancy of regional Australians is less than that of their city counterparts. They have less access to certainly specialty services. So there is perhaps an argument that regional Australians form part of a vulnerable population. You notice there I've highlighted Indigenous. I've used Indigenous there with a lower capital I to represent people that are the First Nations peoples. So that might be the Aboriginal and or Torres Strait Islanders, it might be the Maori people of New Zealand, it might be the Inuits or the Métis of Canada. And maybe just as a simple education, this is something that I've only learnt in the last couple of years. The reason that we capitalise Indigenous in Australia to refer to First Nations people is that we're actually now talking about a very specific group. For those of us in Australia, we are all Indigenous, lower letter I representing that we belong here, but we are certainly not capital I Indigenous to Australia. Perhaps also a quick word about the difference between equity and equality. Many of you might have seen this cartoon before. I think it encapsulates the difference really nicely. The graphic on the left highlights what it's like to have equality. Each of those people has equal access to the crate that will hopefully lift them up over the fence to see the game. And if you'll excuse the pun and perhaps stretching the metaphor a bit far, to make it more of a level playing field, we need equity, where in fact there is redistribution of some of those resources to help those who are less in need. Some of you might have seen the third part of that cartoon, which is liberation, which is taking away the fence entirely. Or the fourth, which refers to capitalism, where the fence still exists, but there's a beautiful grandstand in which the wealthy and the entitled are allowed to sit to watch the game. So I think that there's an important difference there to keep in mind when it comes to equal access and equitable access to resources. What can the core registries tell us about vulnerable populations? I just want to go back a step. I'm going to quickly talk through some of the stuff that Dave went through last month, but with a slightly different emphasis. Most of you will know that day-to-day activity happens in the intensive care. That data is collected, and the core registries contain probably 85 to 90% of all ICU admissions across Australia and New Zealand. Data collectors, the ANZICS registry representatives collect that data. It's mostly uploaded into Comet, which is a sort of a warehouse where the data remains identifiable. It's still linked to a hospital registration number or a medical unit number before it is then uploaded to the core database. And at that point, it's de-identified. Comet collects the adult patient database, collects the pediatric data set, and the CCR, the critical care resources database, is held in a similar spot into which the Comet data is fed directly. Those of you who have been doing the CCR survey will think back to 4 or 5 years ago where everything had to be collected manually and re-entered. Ed and Tamara have done an amazing job of linking them now so that a lot of that is now uploaded automatically. From CORE, which is essentially a benchmarking and quality assurance registry, outliers or differences in processes in care can be identified and fed back to the individual unit and their jurisdiction so that things that might be contributing to, for example, higher rates of mortality in a unit can be identified and fixed. And Dave gave some great examples last month of a personal experience with being an outlier unit and what they did to identify the problems with that. It's also some valuable information is disseminated more widely through the reports, and it's worth picking that up every now and again and having a look through it to see the vast amount and the diversity of work that occurs within ICU across both Australia and New Zealand. As a secondary outcome, there is the opportunity for researchers to access the data from which publications result. And I guess that's some of what we're going to talk about today. So across Australia and New Zealand, again, this is stuff that Dave talked about, presented last month, more than 200 hospitals. There's roughly 200,000 admissions to ICUs annually across the two countries, most of which is to adult ICUs, about 20,000 to paediatric ICUs. And across the years that the data has been collected, there's about 2.5 million ICU episodes of care now held in the database. As you can imagine, that's actually a lot of data. And there's lots of ways that we can look at that data to try and tell us both about what is happening in ICU and the outcomes from patients that are being admitted to ICUs across the country. So let's start with some minority populations, and let's acknowledge that mostly what I'm going to talk about now are Aboriginal and Torres Strait Islanders. I will refer to them as Indigenous with a capital I, acknowledging that that's not always a term that is preferred by Aboriginal and Torres Strait Islanders, but it's the term that we use in the database, so that's what I'll be referring it. That's what I'll be using today. I don't think I need to articulate too much about the gaps that exist between Indigenous and non-Indigenous Australians. What you see there is the closing the gap stuff. There are vast gaps. These are just 7 of the domains in which large gaps have been identified. And despite 10 or 12 years now of lots of effort, really the gaps have only been closed in 2 of those 7. There are still vast gaps in a number of those, including life expectancy. You saw this figure last month from Dave. It shows the number of admissions to ICU over time. It's reflective both of units getting bigger as well as other units joining in to submit data, and units come and go a little bit over time. There's the core group, no pun intended, of units that submit data every year, but there is a smaller group of units that do come and go. Indigenous status was introduced as a non-mandatory field around 2007 and then was mandated as a field in 2011. Those who entered data will know what that means. It means that you need, from 2011, it was absolutely essential to have that field entered. The definition is an interesting one. And again, it reflects the fact that it's a binational database. You'll see there that to meet Indigenous status, the patient identifies as Indigenous to the country where they are receiving treatment. That means that an Aboriginal and Torres Strait Islander person admitted to an Australian ICU will be identified as Indigenous. A Maori person admitted to a New Zealand unit will be identified as Indigenous, but somebody of Maori heritage admitted to an Australian ICU won't be, and that's a current failing of the definition. And if we really believe that ethnic status is an important determinant of health and or contributes to them being part of a vulnerable population, that's something that needs to be addressed, and ANZICS CORE is aware of that, and we're moving forward in a direction that might address that in the next 6 to 12 months. Nevertheless, it gives us a way to identify, certainly within Australia, patients who are admitted to an ICU who identify as Indigenous, in this case Aboriginal or Torres Strait Islander. So what I'll do now is just point to a few publications that have come out over the last couple of years that give us some data about how vulnerable this population is. First of all, Fraser's work, which was published in the Medical Journal of Australia perhaps this time last year, if not a little bit earlier. And what Fraser did was pull out just the trauma diagnoses, both the operative and non-operative, pull them together, and then look at the admissions to ICU, both at a population level as well as individually. And the results are somewhat frightening. You can see them there. So for Indigenous patients, the rate of admission to ICU with, and let's face it, it's going to be severe trauma, is about 3 times higher than the non-Indigenous population. Despite the rates of admission being higher, the illness severity was not all that dissimilar, and mortality was was identical between the two groups. Moving on, this is work that I did with Dave Pilcher and Alex Brown, who's at the South Australian Health and Medical Research Institute. We took a step further back from Fraser's work and looked at how and why Indigenous people were being admitted to Australian ICUs. A couple of things stood out. First of all, there's Fraser's work. Certainly trauma, Indigenous people were overrepresented, but it's sepsis that really stands out. The difference between rates is quite marked. If you're a non-Indigenous person, about 10%, just under 10% of admissions to ICU are associated with sepsis. But in the Indigenous group, it nudged on to 15%. So it's about 1.5 times more likely. What was equally telling is the diagnostic codes for which they were admitted were the areas where they were represented in the opposite direction. So when we looked at admissions to private intensive cares, for example, Indigenous people were virtually completely absent, and they're very much underrepresented in the area of cardiac surgery, despite having very high rates of ischemic heart disease and valvular disease associated with rheumatic heart disease. There were some really interesting things that stood out with the demographics. Most of you would be aware that there are differences in the age distribution anyway, with Indigenous people by and large being younger than non-Indigenous people if you're looking at the population bubbles. But it certainly stood out too in the critical care or the ICU admission data. And in fact, 50% of Aboriginal patients were aged 50 or less as they came into ICU for their admission. That's telling because for most of us, I guess your 5th and 6th decade, so through your 40s and 50s, are probably your peak time of productivity, both from a career point of view as well as for family raising. And if you're ending up in ICUs with your critical illness through those age ranges, you're not contributing back to supporting your family, both either financially or through child rearing. Our conclusions, certainly young Aboriginal people were very much overrepresented in critical illness. Most of you would also be aware that age is one of the things that's important in the Apache score. The Apache 2 and 3 includes age, chronic comorbidities, and your acute physiological derangement. If Aboriginal people are younger, and they certainly are, and their chronic health is not all that different, it must mean that the acute physiological derangement as they come into ICU is worse. And in fact, our data was entirely supportive of that as a hypothesis. Why is it worse? That's an interesting question and something that can only be hypothesis generating at this stage. But we wondered whether it's an equity of access issue, that Aboriginal and Torres Strait Islander people present later, and therefore the physiology is slightly more deranged, which might suggest that there's a access barrier issue. Despite all of that, hospital mortality for the two groups, and including after you've adjusted it for the illness severity, was the same. Will Mitchell, who's a registrar, or was a registrar at the Royal Adelaide Hospital. I think he's off at Harvard doing a master's at the moment, and a group of South Australian colleagues undertook what is an exciting project and almost certainly a harbinger of what is to come. They were really clever, and they linked the APD data for the South Australian admissions with 4 other population level data sets. including a data set that's held in South Australia that identifies Indigenous status, as well as the Registry of Births, Deaths and Marriages, and looked at the long-term outcomes of an admission to ICU if you were Indigenous in South Australia. They managed to get their outcomes out to up to 8 years following the intensive care admission. I highlight it because, you know, this concept of data linkage is it's exciting. It's certainly the way that things are heading. In recognition of that, some of you will be aware that a statistical linkage key was introduced into the de-identified data sets by ANZICS CORE 2 or 3 years ago. So it's now possible potentially to link the data that's held in the APD to a raft of other data sets held at either jurisdictional or national level. They also had some reasonably exciting, it's an interesting word, profound discoveries in their data set. First of all, the longer term mortality was about the same, and the mortality projections followed the population projections for mortality. So Indigenous people certainly died earlier, they died younger, but those trajectories mirrored what otherwise happens in the population. So it would seem that it's not critical illness which is contributing substantially to the mortality gap that exists. It's probably the chronic illness and or the equity of access issues that I've previously alluded to. The other interesting thing that they found, which again probably points to the equity of access, is that Indigenous patients were far more likely to self-discharge from hospital following their ICU admission. And you can call it what you like. I know terminology varies across the country. Locally, we call it take your own leave. In further north of here, they call it absconding, discharge against medical advice, left against medical advice. Call it what you may, but it's probably reflective of a dysfunctional engagement with the healthcare system. And there is something in the healthcare system that Indigenous people are not trusting or are fearful of, which makes them want to leave. It could well be that there are other aspects. There may be some cultural or some family reasons that prompt people to leave hospital earlier than they should. But it also suggests that the healthcare system's not considering those in the care of Indigenous people. So not only were they more likely to self-discharge, but that had a mortality signal. So that group was more likely to die earlier than people that didn't self-discharge. So that gives us an important intervention point where we can spend some time and some work to see if we can intervene and improve healthcare outcomes for Aboriginal and Torres Strait Islanders that is really probably relatively cheap and relatively easy to do. One of those things might be greater engagement with Aboriginal health practitioners and Aboriginal liaison officers. This is not ICU work, but Tamara McKean's done some work in this area, and certainly within the cardiac space, the use of an Aboriginal health worker included in the ward rounds and included in the clinical care of patients who have had an admission with cardiac related diagnosis reduced substantially the amount of self-discharges in the cardiac ward. So again, it's a relatively, in the scheme of things, cheap intervention. It improves health literacy along the way, while also actually improving health outcomes. We can also, and I guess this is the first paper that sort of segues into where vulnerable populations may overlap. This is work that was published 3 or 4 years ago now in the Medical Journal of Australia, looking at paediatric intensive care and highlighted the overrepresentation of Indigenous children in Australian paediatric ICUs with a diagnosis of sepsis. So you would have seen on that very first list of vulnerable populations, that the very young and the very old are usually identified as vulnerable populations. This is where the vulnerable populations start to overlap onto each other. I want to move on now to a different vulnerable group, and this is again, I guess, an area where you see the layering of vulnerability one upon the other. We're going to talk about substance misusers, and in particular alcohol, because we don't really collect much data around other substance misusers in the ANZICS core, but we could. So you've seen this slide. You know that data is held within COMET. That's all hospital level data. That's still re-identifiable. It's linked back to a hospital record number or a medical unit number. It means that sits there. There is within COMET the ability to create customizable fields. They're called tags that will link to either the patient themselves, the hospital episode, or the ICU episode. And you can choose which of those you want to particularly tag. Those of you who are a little familiar enough with the COMET site, you'll be able to find your tag management within the web-based interface. A slight word of caution: you need to be a little careful with your tags. It's very easy for them to get out of control quite quickly. And 12 or 18 months ago, the ability to hide your unused tags was introduced, which makes the management of them a little easier. And because the tag is linked to a patient, a hospital episode, or an ICU episode, you need to have some experience in being able to link data sets, but it's not difficult. And if a numpty like me can pull it together, anybody with any sort of IT skills can do so. Locally, we use the tags. We have used the tags to identify patients who have had an ICU admission associated with alcohol misuse. And the Northern Territory's had a long history of alcohol misuse. Our per capita alcohol consumption has sat between 1.2 and 1.7 times the national average for as long as these things have been recorded. And that's reflected in morbidity and mortality related to alcohol misuse. Hardly needed even to pull out the Northern Territory from that table, which is ABS data, because it stands out with the only jurisdiction with double-digit mortality rates associated with alcohol. Similarly, the hospital admission rates associated with alcohol misuse are higher in the Territory than they are anywhere else in the country, and our road trauma associated with alcohol is higher than anywhere else in the country. So we've got now the best part of 10 years of data around alcohol misuse, certainly within Central Australia, and it's produced a number of publications, the bottom three of which remain sort of in peer review and in or in press at the moment. But that data has highlighted a couple of things for us. First of all, people who have an admission associated with alcohol misuse tend to be younger by about 5 years. Remember that Indigenous people already have an ICU admission age that's about 10 years younger than the average in the rest of the country anyway. And for women at least, that puts them into the childbearing age still. They are more likely to be male. It's about a 60-40 split. Certainly in the Territory, Indigenous people are slightly overrepresented in these figures, but not overly represented, which tells us that alcohol misuse, certainly in the Northern Territory, is not solely an Indigenous issue. Trauma is involved far more often than it should be. So the diagnostic codes associated with trauma are overrepresented in those who have an admission associated with alcohol. And there are higher rates of mechanical ventilation in that group, probably contributing to a slightly longer ICU length of stay. Despite all those things, the hospital mortality between those who misuse alcohol and those who don't seems to be equivalent, certainly related to their ICU admission. We've used the tags, so we've got, as I said, we've got about 10 years of data around that for Central Australia. We've used the tags to expand that to a jurisdiction-wide analysis now. And our Darwin colleagues started collecting this data in about March of 2018. This is data that's sort of under peer review at the moment. 12 months worth of data across the Northern Territory, so both Alice Springs and Darwin, which highlighted that about 20% of ICU admissions are associated with alcohol misuse. You can see the breakdown there. It's about 5% are associated with acute misuse. That's presenting intoxicated or presenting with acute pancreatitis. A disturbing proportion, about 12%, associated with chronic misuse. And this is a group that show end organ dysfunction that is associated with chronic misuse. So alcoholic cardiomyopathy, chronic liver disease that's associated with alcohol, chronic pancreatitis. So that's a substantial proportion, and a smaller but no less concerning and potentially even more concerning group of patients who present with features of both acute and chronic. So they already have the chronic sequelae of alcohol misuse, but are presenting with features that still meet the definition for acute. The data set also has enabled us to start looking at some of the interventions that have been put in place. And this is work that one of our local registrars has been working on. Some of you will be aware that the government has introduced a range of harm minimisation policies, particularly over the last 3 or 4 years, and they include things like the Banned Drinkers Register, which was reintroduced at the start of 2017. What are called police auxiliary liquor inspectors, that's shortened to PALIs on the figure you see there, who are police auxiliary officers who are stationed outside bottle shops in the Northern Territory outside of Darwin, who enforce the harm minimisation policies that are in place. And then finally, the Northern Territory government legislated a minimum unit price or a floor price for alcohol, such that it's illegal to sell alcohol in the Northern Territory for anything less than $1.30 a standard drink. And what Carly's done is look at the rates of intensive care admission associated with alcohol misuse before and after the introduction of the PALIs and the minimum unit price. And I think you can see from that data that although the slope change in the admissions is not quite significant, there is a substantial change with the introduction of those policies. You'll recall too that I said that ICU length of stay is slightly longer in the group of patients who have an admission associated with alcohol. The CCR data tells us that the average cost of an ICU bed is about $4,800 a night. So you can see that if we can reduce the number of patients who have an admission associated with misuse, if that is related to a shortened ICU length of stay, there might actually be cost savings to be had with this as well. What are the implications of all of this? Well, we've just had an election, and it doesn't look as though there will be a change of government, but certainly both opposition parties who were running had threatened to change the alcohol harm minimisation policies quite substantially. And I think the data that we're able to generate out of the core registries, albeit at a local level, inform the public health debate in this space. Let's move on to something else. Pregnant women. That is something that we collect data about in the APD. Matt Maiden and some of his colleagues looked at the presentation rates for obstetric diagnostic codes in an ICU, and although there has been a steady increase in the number or the proportion of admissions to ICU with an obstetric diagnosis, the proportion of those has been reasonably constant over time. You might detect there's a theme emerging because they also identified that Indigenous patients were well overrepresented in the obstetric data. What I didn't highlight with the data from the paper that I did with Dave was that Indigenous patients were overrepresented, but to about 1.4 times what you would expect given their population in the country, which is in keeping with hospital overrepresentation in hospital admissions. Anyway, certainly to public hospitals. In the obstetric data, though, you can see that Indigenous patients comprised 9%, given that they make up 3.8% of the population. That is well overrepresented compared to what it should be. And again, from a hypothesis generating point of view, may point to an equity of access issue for perinatal care for this group of patients. What can it tell us about mental health as another vulnerable group? This paper's several years old, published in Critical Care and Resuscitation. Again, it was just looking at diagnostic codes associated with overdose, representing a mental illness. Numbers increasing potentially. Not completely convinced about the Indigenous and non-Indigenous data in this paper, but I bring it up more as to highlight the breadth of potential data that's held in the APD that might help us manage some of our vulnerable populations better. We can talk about the malnourished. Most of you will know that weight and height have been mandatory fields in the APD now for several years. Weight and height clearly gives us body mass index. And there's been considerable controversy about the presence or absence of what's known as the obesity paradox in the international literature for a long time now. What the APD can tell us about this is two things. One, it gives us the epidemiology of obesity in Australian and New Zealand ICUs, which was not present before we published this data about 12 months ago. And certainly from a nutritional point of view, I think it's important to know what the distribution of ages are. It also highlights the underweight, those with a BMI of less than 18, or although this is not what the paper was about, there's a vulnerable population in there that we haven't looked at in any real detail. But what you'll see from this is that the distribution of obesity in Australian and New Zealand ICUs is roughly the same as that in the Australian population, with the exception that probably the very obese, those with class 3 obesity and above, are overrepresented. And we're also seeing that in some of the Sprint SARI data that's coming out, and I'm sure there'll be some work done in that space linking the APD and the Sprint SARI database going forward. The question remains, does the obesity paradox exist? For those who don't want to know, look away, because certainly in the data that's held in the APD, it seems to. This just plots the odds ratio of mortality across every diagnostic code, adjusting for illness severity, compared to a BMI of 22, being the middle of the normal range. And you'll see the mortality is lowest if you come into ICU with a BMI of about 31. The other thing it highlights is the extraordinarily high mortality of those who are underweight, or if you want to call that malnourished. Those with a BMI of less than 18 have a mortality of between 1.2 and 1.5 times that of somebody with a normal weight. So there's a vulnerable group that we haven't looked at in a great deal of detail that's begging to be done. The very old, this is work that Jai Darvell in Victoria is doing. I think he's doing it as part of a PhD with Dave, highlighting the association of frailty, and again, most of you who are collecting data will know that frailty is being collected as a, I think it's still a non-mandatory field, but will probably become mandatory in the next little while. Putting together age and frailty. We know that age is associated with frailty, but you don't necessarily have to be old to be frail, and we certainly see that in the Indigenous population. And again, that is a project just sitting there waiting to be done at some stage. So, what are the takeaways from this? I hope that I've told you a little bit about what a vulnerable population is, who they might be. I've highlighted that overlap in vulnerable status overlaps, but we're not quite sure what that means. One of the things I certainly want you to take away, certainly those who are collecting the data, is that the data that's being collected is incredibly valuable. It's important to be accurate with it because it informs a lot of decisions that are being made in critical care. And in fact, going forward, it's probably not even to infinity and beyond, but it's to ICU and looking beyond what we're doing in ICU. We have an interface with public health that is important for the health outcomes, particularly these vulnerable groups, but probably actually for everybody that comes into ICU. What do we make of it? I remind you that there's a wealth of information in there. It's sitting there, it's just waiting to be interrogated. Trainees who haven't got a project, please dig up somebody, talk to them about using one of the registries to ask a clinical question of to see if it can be answered. But it does a little bit more than just provide the epidemiology. It provides us some tools to track groups that we think might be important to either individual units or groups of units that share some demographic features in common. And certainly going forward, I think Darwin Hospital and Alice Springs Hospital will start to do more things together, sharing their data sets, using tags to identify patients whom we are more interested in. And going forward, the opportunity exists for clusters of hospitals to get together to coordinate their approach to this. And from my perspective, I guess it makes sense to perhaps include Townsville and Cairns in sort of a tropical cluster that we can use to examine some more data. There is an argument and perhaps a criticism that what we are doing is identifying and measuring problems, but I will remind you that identification and measurement of a problem is simply the first step of any quality assurance cycle. You assess, you measure, you identify where there are gaps in care or where there is a lack of equity in access or differences in processes of care. We make corrections, we then monitor that, and we re-measure to see what changes have happened and whether we need to go through that cycle again. A plug for the critical care datathons. It's a good chance to take a clinical question to a group. Those who haven't been to one, I would encourage you to do so. They're hard work. You leave. It's not a relaxing weekend usually. You leave feeling intellectually exhausted, but they are a lot of fun and expose you to data scientists who have a different approach to the data. I think that's all I wanted to say. So I'll leave it there, and I'm happy to take questions.
Thank you very much, Paul. We'll just give some people some time to actually post a question if they would like. In the interim, I've just got a quick thing to ask you. You mentioned about the Aboriginal healthcare workers, particularly in relation to cardiothoracic units. Is that a model that's being explored generally for intensive care in your region?
So it wasn't cardiothoracic units, it was just cardiac units. So it was mainly cardiology in patients. Not to the best of my knowledge, although speaking from personal experience, we employed an Aboriginal health practitioner in our unit about 12 months ago, and she has proven herself to be absolutely invaluable. I had a family meeting over the weekend with the family of a patient who unfortunately had a catastrophic intracranial hemorrhage. And her ability to sit in the meeting and provide some translation into local language, but also to provide me with clues about whether the message was getting across or not. And in fact, at the very end of the meeting, the family wanted to stand up and pray, and I would have been completely oblivious to that if I hadn't had this little wink and a little indication to stand up, close your eyes, look as though you're doing something, which just helped bond and move forward with the right message. So that's one example of how she's fitted in. I think the work that she does in the unit has proven to us that the role is invaluable.
Especially for the families, that's amazing.
Yeah, and the patients, yeah.
So it seems like a giant leap that we have to, get the redistribution of resources right in relation to Indigenous health outcomes. You mentioned in your MJA article that it might be time for intensivists and indeed intensive care staff to be outside of the boundaries of the intensive care walls. Do you have any tips on what people should be moving towards?
Tips. I think we need to be thinking about that transition between intensive care and the wards. I think we're all cognizant that patients go from a highly monitored, very well staffed environment, often to a environment on the ward where they are certainly less well monitored, and the nursing ratios are very, very different. So it's already a big transition. It's a big transition if you are well educated, speak the language and share the culture of those who are looking after you. If you don't share those things, if you haven't got a family member with you to support you culturally or linguistically through that transition, you can imagine that it would be much harder. Again, linking in with ALOs, which most hospitals now have at least an ALO department, linking them in before they leave to the ward might at least provide a familiar face and some cultural and linguistic continuity as they transition to the ward anyway.
Terrific. Well, Paul, we don't seem to have any questions today, but
that means I've either bored people to death or answered all the questions as we're going.
Not at all. And thank you very much to the nod to our incredible data collectors that are out there every day doing such amazing work, because without them, none of this could be achieved. So I'd like to thank you very much, bring the session to a close. Paul, you have presented something that's very thought-provoking, made all of us much more informed about the differences in outcomes for vulnerable populations. And as I said, I think that our informed knowledge at least helps us be a part of the solution going forward. So thank you very much. Thanks also to all of our attendees who participated today. This webinar has been recorded and will be made available on the ANZICS website in the coming days. Our next presentation will be held on the 23rd of September with Rachel Bailey presenting Staff Perceptions of Family Access and Visitation Policies in Australia and New Zealand Intensive Care Units and the Organisational Perspective using CCR data. So thank you once again, Paul, and it's goodbye from... Oh, we might have a question at the very end, Paul. Can I quickly ask you? Oh, thanks, Paul. Just says, thanks, Paul, for a great presentation.
Thanks, Stephen. Good one. Thanks, Jen. Thanks, everyone, for taking time out of your day to listen to this presentation.
Thank you. And I think everyone's slowly hanging up now, Paul. Thank you very much.
Good. No, thanks, Jen. Good one. Thanks for organising everything.
It's a pleasure. You were absolutely amazing. So we'll actually put that on our website in a couple of days. And so we really thank you very much. It was an amazing presentation. Thank you.
Pleasure. Thanks for organising.
All the best. Bye-bye.
Thanks. Bye-bye.
Bye.